Go live.
Good evening, sir, and good evening, all the doctors attending this session. I take I take this opportunity to welcome you all on behalf of Hetero Healthcare. My name is Chandrakant Maurya. First of all, thank you for joining us today to discuss on the topic of Cariprazine. As you know about Hetero Healthcare, we are the largest R&D wings having 360-degree solution provider, more than 25 years of excellence in multiple therapies. Currently present in more than 126 countries worldwide, more than 200 products across various therapies such as HIV, AIDS, oncology, cardiovascular, neurology, and psychiatry. Distinction of bringing 4 biosimilar products to the market, 36 plus state-of-art of manufacturing facilities, pioneering in quality and innovation. And today we are having Dr. Bharat Sarode, consultant psychiatrist from Pune PCMC area. Sir is having almost 25 years of experience in psychiatry. Sir is ex-class 1 psychiatrist as Regional Mental Hospital, Yeroda, largest mental hospital in Asia, having indoor capacity of 2,640 patients for 10 years, and class 1 psychiatrist at Yeroda's Central Prison for 8 years, largest prison in Maharashtra, having capacity of more than 3,000 prisoners. Past president of IPS Maharashtra chapter, past president of IPS Pune branch, founder, president of Smart Group, organizing chairperson of various conferences at Maharashtra chapter, West Zone and other conferences. Trustee of Vitai Human Kind Development Trust, which runs school and agricultural college. Consultant psychiatrist for more than 25 years. Sir, I request you to please share your experience to discuss more on the subject, sir. Sir, over to you, sir.
Thank you. Uh, First of all, I will really thankful for giving me this opportunity to share my experiences in this field of psychiatry, and particularly this new molecule, newer antipsychotic cariprazine. Please share my slides. Yes, first slide. Uh, Today we will discuss about the newer molecule, which is cariprazine. As we know, in psychiatry, till 1952, there was no any medicine as such to treat the patients. So the first antipsychotic came in 1952, that is chlorpromazine. Till then, there was no any particular medicine or a drug to treat any psychiatric disorder. Then in 1946 or 49, ECT came, and that time only therapy, which our teacher used to say there was only talking and shocking. That is ECTs and just psychotherapies or just counseling for that. But now as we come forward and newer medicine come to our help to treat all sort of psychological disturbances, and particularly treating our various disorders like from anxiety to the more serious illnesses like psychosis or schizophrenia. Because our illnesses are very much due to the medicine as psychiatry part until our MBBS, we were not that. Then when we did our post-graduation, then saw many patients, and as last 25 years, I have seen more than lakh patients in various hospitals. Fortunately, I have got experience in treating these disorders in various institutes like mental hospital, then prison, then many corporate hospitals, rural areas, and in my practice in various small and big hospitals. So lots of experience I got, even medical colleges like Sasun, that is Vijay Medical Colleges. So during these 25 years, fortunately, I got vast experience in psychiatry for treating various disorders. And as we progress, our medical, these pharmacological treatment also progressed. And I have seen all these molecules from fluoxetine to the newer molecule like cariprazine. So today we got various armamentarium to treat various disorders for treating schizophrenia. right from chlorpromazine, then haloperidol, trifluoprazine, older antipsychotic. We can easily group these antipsychotics as first-line antipsychotics or neuroleptics. That is the first generation antipsychotics, which includes like haloperidol, chlorpromazine, trifluoroperazine, pimozide, like that. Then came the second generation antipsychotic, which were equally effective but having a lesser side effect, like olanzapine, aripiprazole, amisulpride. All these then molecule came. But again, because we know various psychological disorders, even after treating, there are many cases which we are they found to be resistant for treatment, or they are not showing much improvement. So newer and newer molecules, the scientists and with the help of these pharma companies, lots of newer molecules came, and we today we are discussing about this molecule, that is cariprazine. Next slide, please. So we will see various symptoms of schizophrenia. Schizophrenia is a very dreaded disorder. In our time, our teacher used to say, like in medicine, it is like a AIDS. That is a very chronic and severe disorder where there is no very helpful treatment. But nowadays, we see hardly patients are there which are resistant, and with the help of newer medications, we can very well treat these disorders. What used to happen in the olden days, there was a lot of stigma for psychiatric disorders, and many patients were not ready to come to the psychiatrist. And many patients, they were not having insight. And relatives were very reluctant, because that time there were no medications, and all these medications were having severe side effects. So they were not ready to take this sort of treatment. And that's why many patients in my practice also, and all psychiatrists might have the similar experience. Many patients used to come after 5 years, 10 years of having suffering of these illnesses, and particularly schizophrenia or psychotic disorders. When patient used to throw stones, or used to harm someone, or harm to self, or he was unmanageable at home, that time these patients were getting admitted to mental hospital, where they were getting admitted and getting treatment. But nowadays, fortunately, many medical colleges having most PG students and PG seats, and many psychiatrists we have produced, and they are going to various places like district places and even in taluka places. 30 years ago, hardly one district having a one psychiatrist, or 3 to 4 districts having a one psychiatrist. And most of the psychiatrists, they were accumulated in the metropolis like Mumbai, Pune, or various big places. And hardly there were psychiatrists in the rural places. But now, district mental health program or various psychiatrists, they are going to various places like taluka places or district places, and lots of health programs by the government or even our psychiatric association. They have given various health programs, and there is a sensitization even in the general population, or even for general doctors, and they are also knowing what is this disorder and they need treatment. And these illnesses are not stigma. They are having various causes of these illnesses, and they are quite well, we can treat them. And many patients who were getting good response, they will go to the society, and they also saying that they got the response, and mouth to mouth there were various sort of health education, and many patients, they are coming to the psychiatrist and getting very well treatment. When I joined mental hospital, there were more than 3,000 patients in the mental hospital. As our population is increasing, patients are increasing, but the patients in the mental hospital, they are decreasing. Nowadays, there are hardly 1,500 or 1,600 patients, because lots of facilities are available at district places. Newer and newer molecules, they are very well, and patients are getting well, and they are getting discharged even from the mental hospital. As there also, newer molecules have come, good treatment come, and many patients, they get very well discharged. And in society also, there is sensitization that these illnesses are not bad illnesses. There is a treatment, and we should go to the doctor. And as soon as we get treatment, patient getting relief very soon. And that's why the indoor patient in getting admitted in the mental hospital, they are decreasing day by day. So we will see about the schizophrenia. Schizophrenia, there are various criteria. In psychiatry, there are two diagnostic systems. One is a DSM and one is a ICD. ICD is the International Classification of Disorders, where all sort of disorders, including all medical illnesses, they are categorized in various disorders. And in DSM, which is Diagnostic and Statistical Manual, which is coined by American Psychiatric Association, and there are a very good criteria. There are two criteria: number of symptoms and duration. When there are certain criteria fulfilled for certain duration, for example, for schizophrenia, it required more than 6 months. If these symptoms are there, like positive symptoms, which are hallucinations, that means there are perceptual disturbances without any stimulation. There may be various hallucinations like auditory hallucinations, visual hallucinations, tactile hallucinations. There are delusions, means patient is having a fixed ideas, fixed and firm ideas. They held for a longer duration, and there many times there is a disorganized speech or disorganized behavior. Patient becomes violent. These are called as the positive symptoms of schizophrenia. When patient go into the chronic phase, they may develop negative symptoms, or even patient having a epiphanic type of the schizophrenia, where negative symptoms are predominant. These are anhedonia, avolition, and blunted affect. That means patient, whatever they are looking, their look is staring look, blunted affect, whatever you call them, there is emotional blunting on their face. And as the progresses, is a progressiveness, which is deteriorating course, and many times in the later stages, we can found there are cognitive symptoms also, cognitive deterioration, where there are memory issues. Many times patient get memory problems, concentration problems, inability to process the cues. So, and even some impaired sensory perception. So these three domains, that is positive symptoms and negative symptoms and cognitive symptoms, all together form the diagnosis of schizophrenia. Once we diagnose schizophrenia, we treat them with antipsychotic and all those things. Even today's molecule, which we are seeing, that is cariprazine, it is also used in mood disorder, that is a bipolar affective disorder or bipolar mood disorder, where there are both. Next slide, please. That is mania and depression. So in mania, there is a higher mode. Why this is called as a bipolar mood disorder? Because there are two poles of emotions. One is a higher pole that we call as a mania or hypomania, and another is the depression. So when both symptoms are there in that patient, then it is called as a bipolar mood disorder. So at some time there may be a manic episode. If there is a manic episode, even first episode, when patient presented as a depressive disorder or in the depressive symptom, and if he develop hypomania or mania, then again it is called as a bipolar mood disorder. And then again there are types of bipolar disorder: bipolar 1, 2, 2.5, 3, and likewise 6 bipolar subdivisions are there. So we did not go in detail. But when patient goes into the mania, then there is a racing of thoughts. Patient talk, he is having a goal-directed hyperactivity. Then patient feels that need of sleep is not there. Many patients I saw in my OPD or IPD practice, they say, sir, I need only 2 hours sleep and still I am very active. And they spend a lot. They took various decisions which are not appropriate, and they are very dangerous. Sometimes these patients becomes violent and they trouble a lot. So many patients, the symptomatology, even this is a spot diagnosis, and many patients needs admission because these are very violent patients, and we have to admit in the hospital and treat them. And once they get the symptoms get controlled on OPD basis, on mood stabilizers and various psychopharmacological treatment, we can maintain them and we can treat them. Then depressive symptoms, they are exactly opposite of what we call manic phase. The patient feels low mood. There is persistent low mood. They feel fatigued. There is a loss of interest in all pleasurable activity. There is a lack of concentration. Many times they feel that memory is not good. that is we call pseudo dementia type of the picture. Sometimes there they happen. Then appetite either decrease or increase. Then there are sleep disturbances. Either they sleep more or their sleep is totally disturbed. Appetite is disturbed. When these symptoms are there for a particular duration of time, then we call this as a depressive disorder. And when they are together or in a longitudinal history, if there is a symptoms like mania or depression, then we can say that this is a bipolar mood disorder. And for both bipolar mood disorder, depression mania, and this schizophrenia or psychosis, in both these disorders, we can use today's molecule, that is cariprazine. Next slide, please. As we see, I told, there are various antipsychotics like first generation or typical antipsychotics. The following medications are typical antipsychotics like chlorpromazine, which I just told, which was the first antipsychotic, which was serendipitously discovered and was found to be useful in psychotic symptoms to treat all these psychological disturbances and symptoms. Then flupentazole, haloperidol, trifluoroperazine, pimozide. These are various molecules which we are using till now. Even older antipsychotics or neuroleptics they used to say, because they were having lots of neurological side effects, and that's why they were called as first generation antipsychotics, neuroleptics, or typical antipsychotics. Then the second generation antipsychotics. Next slide, please. They are second generation antipsychotic. Next slide, please. These second generation antipsychotics, these are previous slide, please. The second generation antipsychotics like amisulpride, aripiprazole, clozapine, risperidone, olanzapine, quetiapine, paliperidone. These were the second generation antipsychotics. Beauty of second generation antipsychotics, the side effect of atypical antipsychotics, they were removed. Their mechanism of action was not on D2 receptors, but also on the serotonergic receptors. So this was like a broad spectrum antipsychotic, broad spectrum antibiotic, or polypharmacy in one drug. But the other side effect, like metabolic side effect, were more. And then again, newer antipsychotic like that is today's molecule, that is cariprazine. So what were the types of antipsychotics? First generation antipsychotics are dopamine receptor antagonists, that is mainly targeting D2 receptors, like phenethiazines, that is chlorpromazine, butorphenols, which is like a haloperidol, thioxanthine, that is clofentazole, dihydroindolones like melindone, and then dibenzapine, that is loxapine. Second generation antipsychotics, they were having antagonized serotonin 5-HT2A receptors and antagonized D2 receptors. So they were acting on the both the receptors, that is serotonergic and dopaminergic receptor. That's why they were also effective in even in bipolar mood disorder or depressive disorder. Example: risperidone, paliperidone, iprasidone, lurasidone, clozapine, olanzapine, and quetiapine. The third generation antipsychotics are D2 partial agonists, and depending on the dopamine concentration, can have antagonistic effect on dopamine receptors. So these third generation antipsychotics, like today's molecule cariprazine, having both agonistic and antagonistic effect, and also they were having effect on the serotonergic receptors. For example, aripiprazole, then brexpiprazole, and cariprazine. Then what were the side effects of atypical antipsychotic, and which drugs are most likely having this side effect? As I told, these typical antipsychotic or these atypical antipsychotic, even we shift to the atypical antipsychotic, which were having lesser side effect, but they are having other side effect like weight gain, then metabolic side effect like increased glucose level, that is diabetes. So most of them, clozapine is having more side effect of weight gain and metabolic side effect than olanzapine, then quetiapine, then risperidone, then depresidone, and aripiprazole. So these were the on a decreasing what we call the these antipsychotic. Then there were having a moment effect like tremors, stiffness, agitation, which were having more in risperidone, then olanzapine, then quetiapine, then ziprasidone, then aripiprazole, and least side effect were having in clozapine. Then sedation. In sedation, clozapine is the most sedative drug, then olanzapine, then quetiapine, and risperidone, ziprasidone, and this sedative is aripiprazole. Then there are side effect on libido also, that is decreased sex drive and functions, missed periods in females, and discharge from the breast, that is increased prolactin level or prolactinemia, which is most common in risperidone, then olanzapine, quetiapine, clozapine, ziprasidone, and amisulpride. So they were having various side effects, both typical antipsychotic, and where now we will see these cariprazine sheets. So, what is the place of these cariprazine in this all these molecules? Then, what are the patient characteristics? Where we can use cariprazine? What are common side effects of cariprazine? Whether we can use this in pregnancy and lactation? Where we can use in children? So, all we will see about cariprazine. Cariprazine is vastly studied and it's available in the international market, and it was approved by FDA in 2017 for bipolar mood disorder, mania, and schizophrenia. Then later on in 2022, it was approved in bipolar depression or depressive disorder. Cariprazine was most often prescribed for patients presenting with their first episode of psychosis. In general, these tend to be younger patients. So it is effective in younger patients as having a lesser side effect. The first line candidate for cariprazines are those with predominantly negative symptoms and those with metabolic syndrome. So those having which were these atypical and first generation antipsychotics, where they are contraindicated or we can't use these molecules, there the role of cariprazine is there. So approved indication, just I told, it is approved by FDA in treating schizophrenia, acute treatment of mania and mixed episodes associated with bipolar disorder, and now it is also approved to treat bipolar depression. Then we will see how in what doses we can use these molecules. So this is available in 1.5, 3 milligram and 4.5 milligram. Its main action is it's a partial agonist of D2 and D3 receptors. Also, it acts on 5HT3 receptors. What mean partial agonist? It is like a mood stabilizer, or it is like a when there is a need, it will turn up the serotonin receptors. When there is no need, it will turn off the these receptors. That means in bipolar depression, it won't allow the switch and it will treat both mania and depression. So such a amazing action of this molecule is there. So starting dose of this molecule in schizophrenia is 1.5 milligram per day, and we can increase slowly to 3 milligram to 6 milligram per day. In bipolar mania, again, we can, as the golden rule, we can start slowly, then we can increase gradually, and we can give optimum dose for an optimum period so that we can get maximum effect of this molecule. What is mode of action? Just I told, clopramazine is a partial agonist of D2 and D3 receptors with significantly greater affinity for D3 receptors. This is partial agonism. This is also having action on 5HT1A receptor, that is serotonin receptor. It is a partial agonism of 5HT1A receptors, antagonism of 5HT2A receptors, and 5HT2B receptors. Minimal antagonism of 5HT2C receptors, and next slide, please. Next slide. So it is having a basically action on various receptors like clozapine. So it is again we can see that this molecule is having very good response. So our various receptors it is having action. So we'll see what receptors will cause what action and how we can use this molecule in various disorders. So its action on D3, where this molecule is acting as a partial agonist. That means there is an improvement of positive and negative and depressive symptoms, and also having pro-cognitive effects like cognitive. There is a sparing of cognition. Then its action on D2, where it is a partial agonist, that is improvement of positive symptoms. Then on 5-HT1A receptor, it is having action of as a partial agonist, where there is an improvement of negative and depressive symptoms. Then its action on 5-HT2A, where it is antagonist, and there is a low risk of extrapyramidal symptoms. Then its action on 5-HT to B, where it is antagonist action and there is a improvement in depressive symptoms. Then 5-HT7, where its action is antagonist and there is an improvement of depressive symptoms and pro-cognitive symptoms. That means this molecule act on all three domains of schizophrenia, that is positive symptoms, negative symptoms, and cognitive symptoms. So there is an improvement of all these symptoms. Then what are the advantages of cariprazine over other typical and atypical antipsychotics? So because of its novel mechanism of action, there is a less weight gain. There is no significant increase in QTC interval. Once daily dosing, as it is having a higher half-life, that is its half-life goes in weeks. That's why once daily dose we can give. Then there is an absence of prolonged titration periods because its half-life is long, and then we can give 1.5 milligram for 1 week. Then we can increase to 3 milligram. Then there are the minimum anticholinergic, metabolic, and prolactin related side effects. And it is most important, it is effective in negative symptoms where many antipsychotics fail. That means this is again a very promising molecule where we can use in these what we call positive symptoms, negative symptoms, and even in the cognitive problems are there or in chronic schizophrenia. When it came to our practice, I got the one patient who was for pretty long time she was not taking treatment. For 10 to 12 years, she hasn't taken treatment and she ran into a very chronic course. She was locking to cell, not doing very well. And she was having impartial treatment at various psychiatric centers and and she was not taking regular treatment. When she came to me, as this molecule was newer, I thought, why not to add cariprazine? And surprisingly, within 3 to 4 weeks, I got surprising result. And her all symptoms, all domain of the symptoms, they improved. Positive symptoms, negative symptoms, and even cognitive symptoms. And then in couple of patients I tried, and later on I got confidence over this molecule. And then many patients which were having a chronic schizophrenia or having negative and negative and these cognitive disturbances, I found very well in younger population as well as in the older population. This molecule was effective. Even later on, where the indications were not told, not approved by FDA, but in our practice, we use many times these molecules for various disorders like even impulse control disorder, borderline personality disorder, sometimes even psychotic symptoms with various drug dependent patient, or when there is a withdrawal or substance related psychological disturbances or psychosis. Even I used in many patients and found very effective. So in short, this is a novel molecule having promising results in bipolar mood disorder, mania, bipolar mood disorder, depression, substance abuse disorder, schizophrenia, both positive, negative symptoms, and even in cognitive disturbances, even dementia patient, where they are having a behavioral and that is psychological disturbances, that is BPSD, behavior and psychological disturbances in dementia. All in all sorts of patients, I have used this molecule and it was found very well results for cariprazine. So in short, this was about this novel molecule cariprazine and my little experience of using this molecule. Again, I am very thankful for patient listening to all. And again, I am thankful to the organizer giving me this opportunity to share little knowledge about this molecule and my clinical experience in this field of psychiatry and using this molecule. Thank you. Thank you very much. Over to the organizers.
Yes, sir. There are some questions.
Yes, sir. We have so many questions been asked. So it was a really wonderful explanation, sir. Just allow me 2 minutes. I'll post all the questions.
Okay.
मला तुमचं कधी कधी एवढं चांगलं
So, sir, the first question is from Dr. Abhishek. What is the maximum dosage of cariprazine in any of your symptoms?
Actually, in my practice and general, I start from a lower dose, and this is my experience for many years. Our Indian population needs lower doses what are prescribed in the Western literature because our patient needs even volume index is our low, and even our patient needs lower doses of all sorts of antipsychotic antidepressants. In my clinical practice, I start from 1.5 milligram, then 3 milligram after 1 or 2 weeks. And if patient is stable on 3 milligram, then I won't increase. Only few patient needs 4.5 to 6 milligram doses. But many patients, they are controlled on 3 milligram in divided doses and slowly increasing the dosage. So 1.5 to 6 milligram is the range of doses. Many patients, they are stabilized on 3 milligrams.
So sorry, sir. Mr. Jain, Mr. Jain,
Yes.
can you help us to mute one participant?
Yeah, over. Done.
Yeah. Thank
Okay.
you so much. Thank you.
The question was dosage for 1.5 milligram to 6 milligram. Maximum patients are around 3 milligram, and very few patients they require higher doses, 4.5 to 6 milligram, but not more than 6 milligram.
Okay. So fair enough, sir. Another questions came from Dr. Priya. So how we differentiate in terms of side effect profile aripiprazole versus cariprazine, sir?
Actually, this cariprazine is like a aripiprazole molecule. Both are like that. So every molecule having various side effects, and they differ from even patient to patient. In my patients, aripiprazole, this is found to be one of the safest molecule having a very lesser side effect. But even though all antipsychotic, they show sometimes movement disorder like extrapyramidal side effect, akathisia, then sometimes there is a sedation, then common side effect like nausea. But we can't differentiate that this is a this molecule side effect is different from another molecule. If someone is in sedation, that sedation might be more for clozapine, lesser for another molecule. But cariprazine, I found in some patients there is extrapyramidal side effect, even though theoretically many newer antipsychotics, even we learn that these are having lesser side effect. But in our practice, it is a common experience of all of us that all molecules having some side effect. It's said that though a molecule having an effect must have some side effect, but comparatively, this newer molecule having a lesser side effect as far as neurological side effects are concerned, and metabological side effects they are more. But for cariprazine, I found there are akathisia in higher doses, then extrapyramidal side effect. In some patients, they show sedation. In some patients, there are some gastric disturbances. Likewise, so cariprazine as having a similar side effect like aripiprazole. Even sometimes, even though we say that there is no any sexual side effect, but many patients they are also showing sexual side effect even with aripiprazole and even with cariprazine. So there is no much difference in side effect symptomatology, but comparatively, this newer antipsychotic having a lesser side effect compared to the older side effect or typical antipsychotics.
Fair enough, sir. Thank you. So one more question came from Dr. Abhishek. As you said, sir, in your slide, it is more favorable in the negative symptoms as well as in cognitive symptoms. So the question has been raised over this topic only. Can it be given in positive symptoms?
Yeah, definitely. Because its action is on various neuroreceptors, including D2 receptors. And D2 blockade definitely having a effect on positive symptomatology. So definitely it is having effect even on positive symptoms also. And many times we can try, or I have also used as a first line therapy in some of the patients having positive symptoms, and it found useful. So definitely, it is also useful in positive symptoms.
Okay. So, one more question came from Dr. Abhishek. In MDD, which antidepressant is suitable with cariprazine, sir?
Antidepressant. Generally, it's a very good questions, and as in our practice, and many of our seniors, or even when we go various conferences, this is a very common question asked, and it's very difficult to treat depression or bipolar mood disorder because we are always worried whether it will switch, or many times it may land into rapid cycling. So many times we have to be very cautiously in our practice and in many psychiatrists' practice and even in my practice, I use all sort of antidepressants in bipolar depression because depressive phase is also in some patients very depressive for them and many times very frustrating because in hypomania or mania these patients are very happy and they won't trouble a lot or they won't feel. But when they land from hypomania, mania to severe depression, it's a worst experience for them. And as a clinician or as a private practitioners, our main aim and our anxiety because they trouble a lot because they have experienced that good experience and the worst experience of depression. And many times they are in a very hurry that their depressive symptoms should go soon. And unfortunately, these depressive symptoms last longer than hypomania and mania. And many times we have to use all sorts of antidepressants. So I have used SSRI, even sometimes even of a generation or they are very good antidepressants, and we have to look that antidepressant effect should go. Theoretically, one shouldn't use potent antidepressant because patient may land into rapid cycling or depressive. But our clinical practice shows that this antidepressant we needed, and very well under cover of mood stabilizers, we can use any sort of antidepressant because our first aim is to relieve their symptoms and then stabilize them. So with cariprazine, we can use these SSRIs, then and even cariprazine itself in a lower dose act as an antidepressant, and many patients show good response on 1.5 milligram cariprazine as an antidepressant effect. Even olanzapine in smaller doses act as an antidepressant. Many times olanzapine and fluoxetine I use a combination to treat bipolar depression. So this question is very good, and the answer is again variable. We can use any sort of combination. First, our aim is to get rid of their symptoms and stabilize them, and there shouldn't be switch.
Okay. Okay, fine, sir. Fair enough, sir. So one question which I personally had, along with, as you said, sir, so along with SSRI, will it be a potent? But what if we used with TCAs, like tricyclic antidepressant? So any possibility?
There are not much studies of combination using drugs, because theoretically one should use monotherapy as less drugs as possible. But in practice, polypharmacy is a rule, and we can't means even treat the patient with a single drug, because it is a these are very frustrating experiences both for patient and relatives to have symptoms for a longer duration and to suffer for a longer duration. So many times we have to use all combination. Theoretically, definitely, in bipolar mood disorder, tricyclics having a higher chances of getting switch. But in practice, we have to use sometimes, depending upon the patient, his symptomatology, and his age and everything, what job he is doing. And depending upon all history, we have to choose a proper antidepressant. But currently, we are using more safer antidepressant like escitalopram or fluoxetine, even sertraline, even venlafaxine. All sorts of antidepressant we are using in various combination, depending upon the symptomatology and our experience to treat these patients. For example, if we treat many patients and they are showing very good response for this bipolar depression, and there is no switch or major side effect, then that molecule is suitable for another patient. So that gives us the confidence to treat this patient. So combination of cariprazine along with SSRIs, SNRIs, or even tricyclics, we can try. And definitely, I think there is no harm if using proper doses and observing the symptomatology and switch and adding appropriate mood stabilizer in various stages. So we can definitely use all these combinations.
All right. All right, sir. So another question came from Dr. Shweta. Can it replace aripiprazole? And I think you have already rectified this kind of questions.
Right? Because the replacement is a misnomer.
Yeah,
Never one can't replace another person or another therapy. So each
yeah, yeah.
molecule having a place for treating that particular disorder. So even newer and newer antipsychotics are coming. Even many patients they are stabilized on haloperidol or trifluoroperazine. So there is no replacement for every each molecule. Even whatever inventions are coming, we can't replace another molecule, because each molecule is having its place to treat that symptomatology and that particular place. We are in India, we have to see even economic background. Newer molecules are many times they are costly, and our experience for years are with older molecules with all seniors. And even in our practice, we see I still use many molecules, and many patients surprisingly they are very much stable on very low doses of typical antipsychotics like Trazini H, where 1.5 milligram of trifluoroperazine is useful. And as soon as there is a we stop this molecule for a couple of weeks, there is symptomatology again, they recur and relapse. So that means each and every molecule, depending upon all these factors, considering the economic also, we have to use, and each and every molecule having its place to use for this, particularly in psychiatry.
All right. Uh, Fair enough, sir. So the next question is from Dr. Manoj, sir. So how cariprazine in acute exacerbation of schizophrenia you used alone or as an add-on, sir?
Generally, my practice, we are having both indoor practice as well as the OPD practice, and OPD practice also at various places and various data. So many times we use various combination, but when there is a acute exacerbation, so depending upon our experience, we generally use the used molecule, which I have used a lot, like amisulpride or olanzapine or even injectable haloperidol. Uh, but in few patients, we definitely add cariprazine in even acute places. But the first choice is again which molecule we have used a lot and we got confidence and experience. Those molecules generally I use. So my first choice is as an antipsychotic still is amisulpride, which I found very useful. Even in indoor practice, we use injectable haloperidol, olanzapine, all these molecules we are using. But slowly we are adding these newer molecules like aripiprazole
Okay.
and cariprazine. So definitely cariprazine having a role in treating acute exacerbation of our older illnesses.
Okay. So I think there is some network issue.
So there is a question how to avoid. Many times patients are very much restless and very troublesome symptoms for both patients. There is restlessness. Okay. So am I audible?
Uh,
Hello.
yes, sir, you are audible, but slight interruption was there.
Hmm.
Okay.
Okay. Okay. Now it's clear.
Now it is clear, sir.
Okay. So what's the
So,
next question?
so, sir, the next question is very frequently asked question. Even I have also seen multiple times this kind of queries comes. So, sir, how do you avoid akathisia?
Right, right. So akathisia is again one of the most common as well as a very troublesome side effect of antipsychotics. So it's both for older antipsychotics and newer antipsychotics, we can see in risperidone, even in amisulpride, even in this cariprazine also, some patients show akathisia. So to avoid akathisia, we have to start very slowly. Then we have to increase the dose very slowly. Again, if there is akathisia, we can add benzodiazepine or beta blockers, where we can very well treat these akathisia symptoms. And we have to switch the molecule if akathisia persists to the molecule where there is a less akathisia like olanzapine and yeah, even clozapine. So where there is a less chances of akathisia, and we can avoid akathisia by using a lower doses, and slowly we can increase the dosage so that patient can get customized with the molecule, and he will not get akathisia. And even the slightest side effect we can recognize early, and we can treat it promptly, and even we can switch to another molecule where it is having a lesser akathisia. Benzodiazepine beta blockers are very good molecules to treat akathisia.
Okay. Okay. Sir, have like any updates on trihexyphenidyl along with cariprazine, sir?
As I told, many patients are showing the extrapyramidal side effect to the molecule where they are having a role in treating this side effect of all sorts of antipsychotics, including these typical or atypical antipsychotics. Many times there are combination like risperidone having triazepinetril combination, then this trifluropyrazine having combination, or even separately we can give triazepinetril. In our practice, generally newer patients we add for 1 or 2 weeks, then slowly we will reduce the triglyphenidyl and we can keep only on that molecule. If there is a subpyramidal side effect, we can add, and if there are no, we can slowly withdraw and patient get tolerated. As we know, as the therapy goes longer and longer, patient get tolerance to the side effect, all sort of side effect, including subpyramidal side effect. So patients slowly get tolerance to both effects and side effects. So that is true. Once we use for a longer duration, no need of triazephenidyl in many patients.
Okay. Okay. So these were the questions were asked from our audience, sir, and I really think that you have rectified all the questions with a proper answers. So thank you, sir. I give the session now, Mr. Chandu, sir.
Okay, thank you again. Thank you all audience for patient listening and contributing their views and asking questions. And I am really thankful to the organizers for giving me this opportunity to share all these things. Thank you. Thank you very much.
Thank you, sir, for your valuable time and guidance. And thank you to the audience for patient listening and getting their doubts clarified. Thank you. Thank you very much, sir. Thank you.
Thank you.
Thank you
good
so
night,
much,
Thank you,
sir.
Edron team. Thank you.
Good night.
Good night.
Thank
Good
you, sir.
night.
Yes,
Thank
sir.
you, sir.
We start
Thank
with
you.
the
Thank you, and good night to everybody.
yes. Good night, sir.
Good night.